And all this kind of thing, when you hear in a lecture, really you don't retain. If somebody's interested, this topic has to be studied. And to study requires time and effort. And now we prefer to have some magic number, but I think it's quite important when we judge our patient. Well, the bicarbonate test, very, very important, is a very, to say bicarbonate test seems something very serious. Maybe serious, but it's something that I personally did since when I was 30 years old, because and we never published that. It born from one simple observation. Coming out from a patient from a surgical theater, let's see, I was measuring 5 milliliters urine in 5 minutes. And the sodium, let's see, was 50 and the potassium was 50. Then I increased the PEEP of 5 of PEEP. Nothing changed. I measured the urine and the sodium was 20 and the potassium 70. Then I changed again in 5 minutes the urine, increasing the PEEP, further 5 centimeters of water, and the sodium was 2, and the potassium was 70, 80. That means what was shocking for me was how fast is the response of the kidney. And all this lecture is based only on one consideration, that the best monitor we have for the volume status is the kidney. And if we look at the electrolytes in the time, it has to put LEDs on this monitor, which is quite simple. One funny thing, as an example, now the patient stopped to urinate. They say, oh, by Jesus, this is a terrible thing. It's a renal insufficiency. If the patient stopped to urinate, what does the creatinine? Goes up. And you call my friend Kerl, Umbellum, and Ronco, and they say, this is acute kidney failure. Maybe it's a perfect kidney which works as much as possible to save the last molecule of sodium of water, because all the signals to the kidney tell, please maintain, take the sodium and take the water, because we need to restore our volume. This is how we are made. So the kidney modification in urine are so impressive to maintain normal status in the rest of the body. And this is sort of the Krebs cycle of the hemodynamic story, because we have problem of contractility, problem of tone, problem of volume, maybe derived from the most different diseases, and we have a common response that we have decrease in arterial central volume, decrease of pressure, we have the activation of the baroreceptors, and we have a series of response and counter-response that are finalized to retain sodium and retain water and to maintain the pressure. That's it. And it's very interesting that whatever happens here, contractility, vascular, we give volume, which doesn't make any sense. I perfectly agree with Marvik with that. But this is the way we handle the problem. Now, how many times happens to you that during the day the resident give 5 liters. During the night, they give a lot of diuretics. In the morning, some people say this patient is very full of fluid. Some patients, and some others say, this patient is very dry. How many times you debate this? Now, what we call the bicarbonate test is just a very simple approach to the problem, trying to ask the kidney. Of course, this is good if the patient is full of diuretics, or the patient is with the real renal insufficiency, the test doesn't work. But on which is based. It's based on a very simple consideration. Let's see. We have skin, we have assessment of volemia in clinical practice. We can do it in different way. We look at the skin, the heart rate, the arterial pressure. I think how the patient looks is extremely important. We have the diuresis, we have a related problem. Everybody knows this kind of thing. I will just arrive at the end of my story to tell you when you have doubt, this patient is full of fluids or is empty. How many times we were discussing before, the patient appears full of fluid, but the vessels appears to require fluid again. Where the fluids go, how the kidney reacts. And I think one system which is possible to use is this one, just to use the kidney. If I give bicarbonate, after the observation I was telling you before, I start to give a small dosage of bicarbonate, maybe 10 millimoles in one syringe. You give quite slowly in 2-3 minutes, and see what's happened. And you divide the patient in 2 categories, no question. There are the patients in which the kidney say, I am okay, and they throw away the sodium, and the pH goes up in 10 minutes. And the patient which say, okay, nothing happens. The urine doesn't change, the pH in the urine doesn't change. These are the patients in which the kidney say, okay, all the signal I receive tell me retain sodium and retain fluids. It's very rough. But, it works quite well. Let's see, this comes from my young colleague, Thomas Langer, when we were giving, and with the study with Caironi, we were giving a series of 0.2 millimole per kilo, 0.3, 0.4, 0.5. And these are the number of breaths. When we give bicarbonate, we give sodium immediately, which is dissociated for the ion, for the bicarbonate ions. Bicarbonate ions is CO2. It's CO2 plus water, which has lost 1 proton. Being a CO2, immediately the CO2 excretion is excreted. And you see that this is the number of breaths. And you see, oops. So you can say, my bicarbonate is bye-bye, it's gone. But the sodium is there. And the sodium, as Pietro showed before, go through the kidney. And the kidney are in a certain status, and the status are avid to retain sodium or are disposed to excrete sodium for the normal regulation of the blood, very sensitive regulation. And if I do the bicarbonate test with the patients, with the patient that are likely avid of sodium, or a patient with the normal volemic status, you see the pH-CO2 does not change. The arterial pH does not change because the amount is very small. The urinary pH, you see, change immediately. May I suggest one thing? Very often our patients have metabolic alkalosis because metabolic alkalosis is due to the doctors, not to the nature, and is due usually to the misuse of furosemide. But if for any reason you have a metabolic alkalosis and a pH greater than 7.45, for 6, for 7, look at the urine. If the pH is acid, is below 6, that means that sodium, that the kidney is in retention. the effective circulating volume into the kidney is sensed as not adequate. This is our monitor tell we are in problem. But if you give a little bit more fluid, or if the pH in the urine is greater than 6, go to 7 and so on, means that you are liberating. You are doing the right, the kidney is doing the right thing because it feels an effective circulating volume which is adequate. And this is the urinary bicarbonate, and these are the urinary variation of pH. I mean, it doesn't cost nothing. And unfortunately, I don't have conflict of interest. I would like to have, because we had asked a couple of companies, after a lot of contractation, they put together the effort to make this prototype, which is up here, which is called Kidney Stand Monitoring so on. We had this prototype available, and believe me, giving the electrolytes every 5 minutes give you a vision of the kidney function which is extraordinary. Unfortunately, they start to fight, and this project is still in the mind of God. But we had the possibility to look how may be potentially important to just put lead to our kidney and to see how the kidney judge our volemic status. You can do without any machine, because probably everybody of you has in somewhere a little bottle with a strip of card when you put in the urine and you look at the pH. Doesn't cost too much, but I think can give you, when you have some doubt, a support to some idea. Of course, I don't tell you if there is any evidence, there is any recommendation to guide therapy, any of this. It's just a little suggestion to try to better understand what's going on. Thank you for the attention.